Excellent. Alrighty, so everyone, today we're here to make MRI image quality feel predictable rather than mysterious. So this whole session is built on one practical idea that image quality is a three-way trade-off between the signal-to-noise ratio, the spatial resolution, and the scan time. If you push one corner, say you're going, I want thinner slices, I want a bigger matrix, you're usually going to have to pay with either one or both sides of those other corners. Images become noisier or the scan becomes longer or both. So in real clinical work, that matters most because longer scans increase our risk of motion, reduces our throughput, and while signal to noise ratio reduces lesion conspicuity as well and confidence. So we want to keep our signal to noise ratio as high as we can to ensure that we're giving the diagnostic yield from our scans. So my goal is that by the end of this presentation, you can look at a protocol change and kind of predict what will happen before you press go. You're able to answer the questions like, is this image grainy? What's my fastest fix that doesn't break the clinical question? And asking yourself, if this breath hold is too long, what can I change first without destroying the diagnostic value of this scan? So we're going to keep it practical. We're going to use lots of console-ready recommendations throughout this one. Alrighty, so our learning objectives for today. We're going to try and bring online in your brain the following concepts. So first, a clear definition of signal to noise ratio. Signal is the coherent tissue information we want. Noise is that random grain we get from the system and the body that we're trying to avoid. Second, we use a single scaling rule that explains most of day-to-day trade-offs. So signal to noise ratio grows with voxel volume and with the square root of acquisition time. So that's why doubling time doesn't always equate to a double in signal to noise ratio. It actually only really gives us sometimes 41% signal gain. Third, we're going to learn to classify each parameter change into a bucket. Does it primarily change voxel size? Does it change how long we sample? Or does it change how effectively we sample? This is how we're going to avoid this random knob turning solution to modifying protocols. We're going to think about it logically and we're going to try and work through it from a more information-based perspective. And then finally, we're going to throw in the clinical judgment. You can never optimize in a vacuum. So the right protocol is dependent on your clinical question. So for example, if we're looking at a axial cervical spine, we want to see that nerve root compression, we need to protect our resolution. Whereas when we're doing an abdomen for a liver and we're doing breath holds, we probably are going to run into some motion limitations. So we're going to have to protect our time more than we're going to have to protect our resolution. So we're going to finish with some fast decision ladders. So if we need more signal to noise ratio, how are we going to do that? These are the steps. If you need faster time, these are the steps. And that's what we're going to work through a bit today. So is it the triangle of death or is it a lover's triangle? This is deliberately a bit playful, but the concept is deadly serious. So the triangle of death is really shorthand for the fact that you cannot optimize signal to noise ratio, resolution, and scan time independently. They are coupled through physics and sampling. So when you ask for higher resolution, you make voxels smaller. Voxels that are smaller contain fewer spins. Therefore, there is less signal being collected per voxel. That's why our signal to noise ratio, often to compensate, we increase our averages or reduce our acceleration, which then results in, yes, more SNR, but then our scan time blows out. Alternatively, if we want to try to keep the time fixed, you then have to compensate by a reduced signal to noise ratio when we're trying to increase resolution. So it's this horrible ping pong playoff between the three corners of that triangle. We just don't want to break the triangle. So when you ask for the higher signal to noise, you're going to typically increase your voxel volume. You can achieve this with your thicker slices and your larger pixels. Or you can increase your sampling time, which is your NEX or your NSA or your averages, depending on what machine you're using. But both cost you. Bigger voxels reduce your detail and they increase your risk of partial voluming artifacts. But then longer time introduces the risk of motion artifacts. So again, this trade-off. If you're wanting shorter time, You can reduce the amount of data being collected. You can do less phase encodings, partial Fourier, or you can increase your acceleration rate. So you can be using more of your parallel imaging. But these strategies are efficient for time, but they're going to cost you in your SNR. And then you can also start introducing reconstruction artifacts if you push the system too hard. Now, the point is, every change has a cost signature. The skill is choosing the cheapest cost, that particular patient, and that particular clinical question. So, why does this triangle exist? Let's unpack that. The triangle exists at a deeper level. So, MRI forms images by sampling spatial frequencies within the K space. Higher resolution means you're either going to sample higher spatial frequencies, so more K space extent, or you're going to sample more points to represent the object without aliasing. Both are very data hungry. Signal to noise ratio is essentially a ratio. So how much coherent signal did we measure relative to the random noise? You increase your coherent signal per voxel by using larger voxels or by collecting longer and averaging. Noise doesn't average down linearly. It averages down with the square root of time because noise is random. So time helps, but it helps slowly. Scan time is limited by physiology and workflow. Longer scans mean more motion, more fatigue from your patient, more repetitions or repeats, and less throughput. So in clinical practice, time is the most fragile corner of that triangle, especially when you're working with well or anxious type patients who might not be able to remain still or suffer from that fatigue. So the triangle is not a rule made up by physicists. It's direct consequences of one, your voxel size, controlling how many of those spins contribute to a measurement, and two, your K-space sampling, controlling how long acquisition takes, and three, the square root behavior of noise averaging. So we're going to talk a little bit more about signal to noise ratio. So we define SNR in practical terms. If you zoom into a uniform region like the CSF or the liver, the signal, it means that the brightness coming from that tissue is the signal that we're wanting to see. The noise is that random bit of speckle that makes the brightness fluctuate pixel to pixel, even when the tissue is uniform. SNR is just signal divided by the standard deviation of noise, so it isn't doubling and linear in that way. So in clinical sense, lower SNR makes pathology harder to see because lesion conspicuously depends on the difference between two tissue relative to the noise floor. Even if contrast is present, the high noise can make subtle differences. So that's why noise, it can mask subtle differences. So that's why the noise can be non-diagnostic, even if the sequence has the right contrast. So two important clarifiers is first, SNR is not the same as contrast. You can have really great contrast in your images, but really poor SNR and struggle. Second, not all ugly images are inherently low signal to noise. Sometimes you're seeing artifact from aliasing, motion, or susceptibility, and it's not actually random noise that's reducing the quality of your images. So a large part of your protocol design is distinguishing between noise and artifacts so that you can adjust the right knob. So if anyone has ever wondered what an eggplant looks like on an MRI, this is your opportunity. So I have scanned an eggplant in multiple different ways to be able to demonstrate the difference in some of these knobs and these different parts of this triangle. So this is Mr. Eggplant. So Mr. Eggplant has been acquired with a axial T2 sequence just from the routine library of the Siemens scanner that I was using. So the first image that we can see on the far left is a routine sequence pulled. The middle image is where I've reduced the averages from 2 to 1. And then the one on the far right is where I've increased the averages from 2 to 3. When we're zoomed out, it doesn't really be apparent of how different the averaging and that signal to noise is. You can tell obviously on the far right, that one does have a lot more signal. and the one in the middle is starting to produce a bit of that grainy background. But it can be really hard to appreciate these small structures on a zoomed out image. So what we've gone and done is we've zoomed it in. So this central component here, we have zoomed right in. So on the zoomed up images, we can now see that by dropping our averages in that middle column, we have introduced noise into this image, which has reduced some of that conspicuity, some of those finer details, which could be difference between spotting a lesion and not spotting a lesion. So in these examples, you can also see time has taken a huge difference between the three as well. Our original sequence was roughly 4 minutes. Dropping our average reduced our time by half, and we came out with 2 minutes, but then increasing our averages brought us up to nearly 6 minutes. So again, everything's a trade-off. But in MR, SNL signal to noise ratio feels like image grain. So when we have high SNR, the tissue will look smooth and boundaries are crisper, which is what we can see on that far right. We do have the smoothness, but we are losing some of that conspicuity as well because we've lost that resolution because we haven't accounted for that in our triangle trade-off. How this relates to a real-world example? Well, in this really fantastic study, we can see the difference between SNR and its ability to pick up small lesions. So clinically, here we have a conventional post-contrast 3D MRIphysics on the left. Its acquisition time is 4 to 5 minutes. Then on the right, we have a 3D MRIphysics flash with an acquisition time of 1 minute. So in this study, the same patient had post-contrast, MRIphysics, and then the flash equivalent. The flash was noted within the study to have a lot lower signal-to-noise ratio than the conventional sequence. And as such, that really small enhancing MS lesion that we can see on this first one, we actually can't see on the second one. So if this was the very first multiple sclerosis lesion that we were seeing on this post-GAD patient, we would have missed it if we had run just the flash sequence and not have done the full 3D imaging. And this was accounted because of the signal to noise ratio dropping between the two sequences. So this is a really fantastic example of how SNR can influence the diagnostic yield of our images and adversely affect the outcomes. So we have to ask ourselves, what was the clinical question being asked for this one? So if you're looking for a small lesion, you must keep your SNR really nice and high. But if you're looking for something like a macroadenoma, a pituitary macroadenoma that you know about, well, maybe we don't need to keep SNR as high because we already know it's present and it's quite a large tumor that we're already looking for. It's not micro. So just checking what our clinical question is and making sure our protocol fits. So next is our core relationship. So this is the single most useful scaling rule. Signal to noise ratio is proportional to voxel volume times the square root of total acquisition time. So said differently, if you double your voxel volume, you roughly double your signal to noise ratio. If you quadruple time, you roughly double SNR. So why does this matter? It tells you immediately why some protocol tweaks feel really powerful and others feel really disappointing. So when you're increasing your NSA or your averages from 1 to 2, you can see it's really noticeable because 1 to 2 is 2 squared. So it's a 41% gain in your SNR. So that's why 1 to 2 feels really good. But then if you're increasing from 2 to 3, that's only the square of 3 over 2. So you're only gaining 22% when you go from 2 to 3 in your averages. And yet the time penalty is 50% more. So it doesn't feel as good because you haven't received as much gain for the tax that you're receiving on the other end of that triangle. So the voxel part is even more dramatic in this case. If you reduce your slice thicknesses from 4 millimeters to 2, you halve that voxel volume. So your signal to noise ratio will roughly half unless you find a way to compensate for it. So to regain that lost signal to noise ratio by time alone, you would need roughly 4 times the time to gain back that SNR because SNR grows as a square root over time. So this is why high resolution is so expensive. Small voxels are a double hit, less signal per voxel, often more K-space filling. Practical takeaway is you have to try to protect your resolution only where it is diagnostically required and be strategic on where you spend your time. If you don't need that really high resolution, let's say you're looking at a liver, we don't need to get 1 millimeter slices on our axial hastes or T2 fat suppressed sequences. Maybe we can go 3 or 5 in most cases. It's thinking of where do I need this resolution? Do I need to tax myself with that time? So voxel volume, what am I talking about? What is it actually? So let's make it concrete. Voxel volume is the slice thickness multiplied by pixel area. So pixel size is determined by your field of view, but then divided by that matrix in each direction. So if you have thicker slices and a larger field of view or a small matrix, all increase your voxel volume and therefore your signal to noise ratio. But, and this is crucial, different changes have different side effects, like that triangle. So when you increase your slice thickness, you're mainly going to harm your through plane detail and increase partial voluming effects as well. Changing your field of view can change your anatomy coverage and you start introducing an aliasing risk, so that fold over artifact that we can get. Changing your matrix changes in-plane sharpness and can change your scan time if you increase your phasing codes. So practical way to teach this would be to show a protocol and we can say, what is our voxel? And if you can calculate your pixel size and slice thickness, you can then predict what your signal to noise consequences will be. So for example, if we have a sequence where it's 0.8 by 0.8 by 3 millimeter slices for our voxels, and we move to 1 millimeter by 1 millimeter and then 4 millimeter slices, our voxels increase and our voxel volume will increase. And then what will happen is you'll go, the lovely little equation that we can then plug in like that slide. And what happens is from that equation alone, we actually get a 2.6% increase in our signal to noise ratio when changing from 0.8 to 1 and 3 mils to 4. But we're going to take a hit with our spatial detail in that resolution. So voxel volume is a lever, but clinical judgment decides if you're allowed to pull it or not. And that's going to come back down to talking about what is your clinical question and what are we looking for on our scans. Do we need to keep that resolution high, or can we use larger voxel volumes? Can we use a larger slice thickness? And that's going to come down to a discussion with your radiologist as well, because at the end of the day, they're the ones that are making a clinical judgment on the images that we're producing. So partial volume, it really is a hidden enemy. Partial volume is the enemy of diagnostic MRI. So it occurs when a voxel contains a mixture of tissues. So for example, if a disc and a nerve root or a lesion and normal marrow are all combined within the one voxel. The voxel reports the average of the signal, so that can make the pathology disappear or create misleading, intermediate, or indeterminate signal. So this is why thick slices can hide these small lesions, even if the sequence has really good contrast. Partial voluming is not that random noise that we're seeing. It's the systemic blurring caused by that voxel size, because the voxel is picking up signal from different tissues or different things and then averaging it out. So how can we recognize this on our diagnostic images? So we can look for structures that change dramatically across adjacent slices, or you can look for a smearing along a slice direction. So in a brain, it could be small lesions may appear on one slice and then vanish on your next one. In a spine, it could be the foraminal pathology may appear inconsistent between sequences. How can we fix this? So if we're finding that we're getting partial voluming or our voxels are too large, we can reduce our voxel size. So we can achieve this by things like our thinner slices. We can opt for smaller pixels, so increasing our matrix, or we can use 3D acquisitions with isotropic voxels. Because those voxels are isotropic, we're going to reduce that risk of that averaging. But remember, you're always going to have to pay with signal to noise and or with time. So practical recommendations if you're finding that you're getting partial voluming artifacts for high stakes, small structure questions like metastatic disease, looking for small mets, looking for microadenomas in the pituitary, protect that resolution and earn back your signal to noise ratio with things like really good coil positioning. If you're not positioned well within the coil, you're not going to maximize your machine's capabilities. So make sure your coil positioning is spot on. Next, modest increases in your averages, nexts, or NSAs to be able to draw back, but also keeping in mind how you're achieving that with the time. Another approach is you can reduce your acceleration to give yourself some more signal back as well. So back to Mr. Eggplant. So we have some different images here, which is a 3 mm slice, a 6 mm, and then a 12 mm. Now, slice thickness is the fastest way to change your voxel volume to get that SNR back. So it is a really powerful SNR tool. But think of bigger slices like big buckets. We're collecting lots of different signal, and thin slices like smaller buckets collecting less signal. When you increase that slice thickness, SNR rises thoroughly in proportion because you are increasing that voxel volume like we spoke about. So that's why a noisy image can be often rescued by probably a small or moderate increase. So going from 3 mm slices to 4 mm gives you about a 33% signal to noise ratio boost, which can be clinically meaningful. So going from 3 to 4 mm might be perfectly fine to be able to answer a question like if we're doing a lumbar spine for sciatica, maybe going from a 3 mm to a 4 is clinically acceptable for your radiologist and the decisions being made. So while we're looking at these images, we can see we've got a beautiful scaling of our signal to noise. We are gaining back a lot of signal within the first, the last. But what are the consequences of going rogue and doing really big slice thicknesses? So this slide kind of reinforces what partial voluming can happen within this. So thick slices are like taking a photograph with a motion blur in the slice direction. So different layers of anatomy are being blended into one measurement. This blending can mimic pathology or hide it. So in this example here with the eggplant, we can see that we're losing the ability to differentiate these three very, very small white dots, which doesn't mean much when we're looking at an eggplant. But clinically, if this was small metastatic disease or missing an exiting nerve root in a spine, this could be clinically significant. So again, it's just relaying everything back to, am I still going to solve the clinical question if I pull this lever? So classical volume traps can include, like I said, exiting nerve roots, small cord lesions, things like drop mets can be hard to see. Subtle meniscal tears within the knee. If we start increasing our millimeters and our slice thickness too much, we are going to miss more subtleness within knee structures or joint structures. Small bone marrow lesions we can miss as well. And thin cortical lesions as well are going to be missed if we start increasing our slice thickness and going rogue and not really accounting for what we're looking for. So if a radiologist says, I can't tell if that's real or not, typically this is what they're talking about. It's partial voluming is usually a large contributor if they don't know if something is real or not real. So the practical recommendations for this is use slice thickness as a rescue knob. So when the clinical question tolerates it, especially when you're dealing with things like motion limited or low signal to noise ratio situations, if the clinical question depends on thin slices, then don't pull this lever. Find your signal to noise and earn it back from different ways like coil optimization, modifying your averages and your nexts, and reducing any unnecessary acceleration to gain that signal back instead of going straight for the slice thickness. Here is a really good real world example of what can happen when we start pulling the lever of slice thickness without thinking about the contributing factors. So these are examples of some reconstructed slice thicknesses from a 3D acquisition for brain metastatic assessment prior to stereotactic therapy. So researchers in this one highlighted that this is what happens when you increase your slice thickness from 1 millimeter to 2 millimeters to 3 millimeters. So in their data, 13 metastatic METs were missed across 7 patients when they increased from 1 millimeter to 3. So this just highlights the case that slice thickness to increase our SNR can't be our first lever to pull when we're thinking of how do we get signal back. We really need to think about the clinical context because, like in this example, if we are looking for METs, we might miss them by increasing our slice thickness if we don't think about why we're doing it and what we're trying to achieve. So always have the clinical question at the forefront when you're thinking about how do I gain back and when you start thinking about slice thickness as the option. Next, we're going to talk about field of view. So these 3 images of the eggplant were acquired with different fields of view. So they've all been zoomed up to be the same image size roughly, but they were all acquired with different field of views. So there is a large difference between the 3. So you can see that these are the product of their matrix staying similar and the pixel dimensions changing. So if we increase our field of view without considerations of other consequences and parameters, this is what will happen. We will zoom in with our field of view and we get the first image here, which is very, very grainy. And then on the end, if we zoom right out and use a really large field of view, this is what we're going to result in when we zoom everything up. Let's get even closer. So this is what happens when we really zoom it up. So we can see that with a smaller field of view, we are retaining our ability to differentiate between those 2 tiny little adjacent structures. So these 2 high in signal intensities that I've circled in yellow. And on our conventional one, we can see that they're 2 separate entities as well. But once we go to the large field of view, we're seeing that we're losing our ability to differentiate these as 2 separate structures. So when we compare these together, we're again asking when we're doing a field of view, are we answering the clinical question and are we running the risk of blurring information together and losing our ability to differentiate structures? So here's some really good images of what this can look like clinically as well. So we can see that from a zoomed out look, the images are acceptable, but no radiologist is going to want to report on number A. They're going to look at that and go, gosh, our field of view is huge. Why have we zoomed it right out? And the brain is small. So they're going to have to zoom that image up. And then that's when we're going to see a lot of that blurring as well, if we haven't accounted for the other parts of that triangle. And then when we zoom in and we have a small field of view, this one, we haven't introduced any aliasing issues, but we can see down here at the sagittal sequence, this is what will typically happen if you have too small of a field of view and you haven't accounted for the anatomy. You're going to start introducing this wrap onto yourself, depending on which way you are phase encoding, which way you're acquiring. So this is the consequence of having a really small field of view that's within the anatomy still, but not accounting for anything else and keeping our protocol without oversampling. So if we are aiming to try to get a really small field of view and the anatomy is within that box, we really do need to think of other ways that we can reduce introducing that wrap artifact and that aliasing, which is going to be coming from maybe oversampling, or if the clinical question really doesn't need that really small field of view, we can consider a larger one as well. So time. Why time only helps as a square. So let's explain why time only really helps as a square root. So noise behaves randomly from one measurement to the next. When you average repeated measurements, the true signal adds coherently, but random noise partially cancels out. So statistically, the remaining noise will decrease as a function of 1 over the square root of n, where n is the averages or NSA or independent samples that we're doing. So that's why when we double our nexes, NSAs, and averages, or we double our phase encodings, it doesn't result in doubling our SNR because it's not that kind of relationship. It improves by the square of 2. And this is a common trap. A lot of people add lots of time expecting lots of dramatic improvement in their SNR or resolution. And the problem is the image potentially becomes grainier or becomes progressively smaller. It doesn't always result in the effect that we think we're going to get. So we have to think about the relationships and the physics and the maths that's tying these all together. Another good point is time is not just a physics cost, it's a true clinical cost. So as time increases, we have motion, we have drift increase, we have patients who might not be able to keep holding still for us. So there is a sweet spot. We need enough time to get stable image quality, but not so much so that the patient becomes fatigued and starts moving and destroys the benefit of what we've tried to achieve. So the rule is this: spend time on your signal to noise ratio when motion is controlled and the gain is worth it. If motion is present, your priority is usually to shorten your scan time to reduce your motion artifact, even if it comes at a bit of a cost of signal to noise ratio. You're better off to have an image with a little bit of grain and noise versus an image that is completely of no diagnostic yield due to motion artifacts. Think about the clinical question. It always comes back to that. Next one is our practical signal to noise ratio knob. So what are we going to start turning on our quick knob map when we're thinking of how do we tweak this protocol? So when juniors are learning protocols, it really helps to group these parameters by what the primary effect will be. So if we need our voxels, if we need more signal into them, we can change our slice thickness. Again, everything should relate back to the clinical question. Will increasing my slice thickness decrease my ability to produce the results and the diagnostic yield of my imaging? Next, we can think about our field of view, and then we can think about our matrix as well. So these changes will change the voxel volume, and these therefore will give us the signal to noise ratio or our resolution. When we need to increase our sampling knob because we want to increase our signal to noise, we can go, cool, we can use nexes and averages and NSAs. We can have a look at our phase resolution. We can have a look at the number of slices that we're doing as well. These change how much data we're collecting and therefore can save us time, but also remembering that time is a square root and of signal. So we have to always be considerate of, are we actually achieving what we want to achieve? Are we going to get the results for the time we're spending? And then efficiency knobs. If we want to really speed things up, if we're like, okay, we just need to get through this, our patient is really struggling, we can look at things like our parallel imaging, our partial Fourier, and if we have the ability, compressed sensing. So these all reduce our time by collecting less data and using priors. But this typically will then come at that cost of our signal to noise ratio, and we can start introducing artifacts if we're not careful. Next is our system knobs. So this is looking at our bandwidth and our coil and our field. So bandwidth is a classic signal to noise ratio versus artifact trading off. Our coils and our field strength are free signal to noise sources if chosen and well positioned. So keeping everything at ISO center is really, really important and able to get us better image quality. If we haven't taken the time to get our patient in ISO on the ball, we can put ourselves at risk of having decreased image quality because of the off-centering, especially when we're looking at things like our fat suppression. We'll get fat suppression failure if we do not account for off-centered or off ISO positioning. So it's really important that we consider where our coils are placed in space and time within our machine, if that's going to give us the best image quality we can, and ensuring that our coils are connected appropriately. Something that happens with a lot of juniors is if they're rushing to put the second part of the head coil on if you have a two-part system, or the top part of a knee coil if you have, again, a two-part system, they sometimes do not connect the coil fully, and some systems will not alert you if it's not correctly clicked in. So that will result in grainy images and loss of signal. So just making sure that we are positioning our patients well and we've considered that the coil is fully connected to the system and where it sits is a really good basic one, especially when we're working with a lot of junior radiographers. So some practical recommendations. When someone asks you to optimize something, don't start cooking and go for 5 knobs at any one time. It's exciting to click all the buttons, but it's going to be so hard for us to understand if we're doing multiple ones to then backpedal and go, okay, which one did work and which one didn't work. So try to change one lever at a time. Kind of predict your outcome and what result you're wanting, and then recheck after you've run that sequence. It is slower and it can feel really slow, but this is the best way to be able to control the outcome. If you go and adjust a million things, it's going to be really hard for you to understand if one didn't work and where we went wrong. So by going one at a time, for a seasoned MRI radiographer, we can go in and go, cool, I know I've got to play with these four things. This is the result. But if you're a junior, do one at a time to build your intuition. This will avoid you making accidental non-diagnostic outcomes that's going to tax you for the sequence that didn't end up working. So do one knob at a time, one fix at a time, and that'll help you immensely in building your intuition as you grow in this modality. Last one of that corner of that triangle is our resolution. So what does sharper actually mean? So when someone says make it sharper, clarify what that means. Do they want sharper edges in plane? Do they want thinner slices through plane? Or do they want both? Sometimes it can be really hard understanding what someone is wanting from your images. So get them to make it clear what they need from you and what they're trying to communicate to you they want to understand and what they want. So in MRI, resolution is fundamentally our voxel sizes. So small voxels resolve small structures. Big voxels will blur them. So in-plane resolution is our pixel size. So our field of view divided by our matrix will give us our pixel size. Most systems will tell you what this is anyway, but if you need to work it out, that's how you do it. So your through plane resolution is slice thickness. So both of these things influence your partial volume. So many missed lesions are partial volume problems. Actually, they're not contrast issues. So if you're struggling to see those small lesions, it's probably because your slice thickness is too big or your pixel size is too large, and we're averaging out that lesion. So again, what is our clinical question? What are we trying to answer? Now, the trade-off is when we do those smaller voxels, like we've said a few times now, your signal to noise becomes smaller and less because you're getting fewer spins in your bucket to contribute to each voxel. And then you'll need to compensate for your averages or with better hardware, or we accept the noisier image. Sometimes noisier images are going to answer the clinical question better than a less noisy image that has larger voxel sizes and partial voluming. So again, it comes down to what are we trying to answer? So some practical examples is if you're doing an inner ear or internal auditory canal, if you're doing a pituitary, if you're looking at small MSK structures like a scaphoid or a subtle cord lesion, you need to protect that resolution. If you're doing broad screening where you're worried about motion and speed and throughput, you can accept that slightly lower resolution in order to preserve your time and reduce your repeats. So resolution is not good or bad. It is the clinical choice, and you're coupling it with your SNR and your time tax. So welcome back to Mr. Eggplant. So we're going to talk about that resolution tangibly with these images. So between the two images of this eggplant, we have one that has large pixels that smooth everything out. So the one sort of on the right-hand side, with left-hand side, we're getting our normal resolution, and the one on the right is a higher resolution. And so what we're going to try and look at here is the one on the right with the higher resolution. We are getting more information because we have smaller pixels, but we are getting a grainier image. So it's going to be a little bit noisier. So if you just go straight to changing your resolution without thinking about your SNR and your time, this is what will happen. So we went from 4-minute sequence to a 5.5-minute sequence, and we've introduced more grain and noise within it. So when we're looking at these images, and I do this with my juniors, is if you want to test to see if you've pushed your system too hard with your resolution, zoom it up, go into your 200% and look at your edges of your images and structures. If they look blocky, it's your pixel size. If structures disappear within your slices, more of a slice thickness issue. So our practical recommendation would be for in-plane detail, maybe reduce your field of view to the anatomy rather than simply just increasing your matrix across a large field of view. What this will do is it keeps your matrix reasonable, it controls that time issue, and it targets that resolution where it really matters. So instead of going, oh, yes, I'm just going to increase my resolution, think to yourself, actually, can I just reduce my field of view? And then you'll be able to navigate that issue for there. Now, if you're going for through plane detail, consider 3D acquisitions when feasible, just because they organically provide thin, continuous slices and they allow you to do reformats as a troubleshooting approach. Then, in keeping, 3Ds are usually more taxing with time, and you usually have to rely on an acceleration. So, think, is that actually going to answer the clinical question that I'm struggling with my two-dimensional sequences? Will this 3D fix my problem? So a big takeaway is more resolution, it really needs to be targeted. Can't just be a blanket rule for everything in every sequence. Don't pay the resolution bill across whole studies if it's only really one region that needs to be looked at. So when we zoom these two ones up on the next one, we can see down the bottom here, we've got the voxel size. We've gone from the reconstruction, which is the 0.24 to 0.19, and our acquisition went from 0.35 and 0.24 to 0.27 and 0.18. So we have drastically increased our resolution on this one, and we've maintained our 3 millimeter slices, but we have paid the time tax here. We have gone from 4 minutes, we've added an extra minute and a half on. And then we've also introduced a little bit more noise into our image. Unfortunately, so what this means is we have a large time penalty, a minute and a half, and we've lost about 30% of our signal. How this works in the real world, here's a beautiful image of the spine, okay? So same patient, scanned twice. First one on the left is with a standard 1.5T scanner back in 2022, and then they had one on a 3 Tesla scanner a couple of months later, and the image on the right. So the key point here is that just organically, a 3T tends to have more signal. And in this imaging, we can see the benefits of what happens when we have more resolution. So the stronger the magnetic field, we're going to get more signal to work with, and we can spend that more on that spatial resolution. So we're getting finer anatomical detail here and those clearer borders within between the structures. So for this patient here, it's really nice to appreciate that herniated bulging disc on the 3T versus the 1.5. And we are getting a lot more structural information on that posterior chain as we go down, so we can assess that spinal cord and if there's any like tethering of the called equina into there and where the 𝐋𝐕 nerve roots are too. So this is where resolution plays a very good role, especially when we're looking at our nerves, looking at really small, fine detail. The scan time, where it comes from, a bit more on how you can control it. So when we're talking about scan time, we want to understand where time comes from that makes you confident and efficient, and what happens when you're working with a patient who can't tolerate a long study. So a simple framework can be that scan time is roughly your TR multiplied by the number of TR repetitions. So the number of repetitions depends on how much K space we need to fill. So in our 2D imaging, the big drivers of this is our phasing codings and our nexus and averages. In 3D imaging, it's our partitions, add another dimension to this, and encoding. So we can blow out time really easily in a 3-dimensional sequence as well. But time, it's not only a resource, it is a quality factor because motion artifacts will arise when your time blows out. Sometimes the best quality improvement is actually to shorten the scan and reduce your movement, even at that cost of the SNR, like we were saying before. If your patient isn't going to hold still, you're better off to have a reduced SNR image and still have a diagnostic sequence versus one that is completely degraded because the timing was too long because we're trying to maintain high SNR, but we've introduced a lot of movement from our patient. So that practical question is the limitation our physics or is it our patient? Is the patient breathing or moving or unable to do what we need them to do We then need to switch gears and we need to prioritize our time reduction strategies. So that's going to preserve that diagnostic image. If our patient is stable, we do have the time for it in our bookings. If the image is noisy, you can spend that money to buy your SNR back. But think about the clinical context, think about your current situation. Is that actually what you need? Use your clinical judgment. This is a big thing in MR. It's all about your clinical judgment and understanding where you can and can't buy that time back. So when we're talking about our 2D spin echoes and fast spin echo sequences, time is usually controlled by a smaller set of knobs. We have our TR, phase encoding steps, our nex and averages, and our echo train length, which is our turbo factor or ETL. So our TR is a multiplier. If we increase our TR, we're going to increase our time proportionally. TR is also a big thing that comes into our SAR monitoring as well. If we want to maintain SAR, our system might ask us to increase our TR. If you're using a Siemens, that usually is one of the prompts to increase your TR, but it will increase your time. Phase encoding steps determine how many lines of our case space we are collecting. So more phase lines means more TRs. Next, and our averages repeat the acquisition. So this is more of a linear relationship. So our echo train length and turbo factor is a speed lever in fast or turbo spin echoes. You can collect multiple lines per TR and it can reduce your time. But when you have a high echo train length, you can introduce that blur and you can alter your contrast because later echoes have more T2 decay. So it's going to come down to what your sequence is. If you're going for a T1, you're going to have to abide by a smaller echo train. And then if you're going for a T2 and STIRs, you can use higher. You can't push the system too hard, otherwise you are going to introduce that blur. And that's going to take away all the benefit that you've tried to get back into your images. So practical strategy can be that if you need to shorten a two-dimensional fast or turbo spin echo, first consider a moderate reduction in your phase encoding and a moderate increase in your echo train length if image sharpness remains acceptable. So you're wanting to watch out for that blur introduction. If you need more signal to noise ratio and you can tolerate the time cost, consider your averages. If you need both speed and signal to noise ratio, you may need to adjust that voxel volume rather than relying on your acceleration, but you will pay for it with your resolution. So the key is to change one drive lever at a time, observe, and then adjust from there, especially when you're starting out. So when we go parameter with some technical details, so we're going into the knob by knob thinking. So the goal from this one is, what are our 3 knob questions? So number 1, what does it do to my voxel volume? What will changing this protocol right now do to this, to my resolution and my signal to noise ratio? What does this do to my time? How much am I blowing out my time? Is my patient going to be able to do this? And then what artifacts am I potentially introducing if I do this? How can I mitigate those? And this is how you develop more protocol intuition. So an example could be your bandwidth. So that's primarily a signal to noise versus artifact knob. If you're going for your averages, it is primarily a SNR for time knob. If you're going for parallel imaging, it is a time versus signal to noise ratio knob. And you have to consider the artifacts you may be introducing. So by the end of your thought, you should be thinking, am I able to take a clinical request? Can I make it faster, sharper, and less noisy? And what are my shortlist options of parameter changes right now? And what am I asking? What is my clinical question? So avoid knob stacking. So if you can, do not go and change 4 or 5 things like we said before. Change one thing at a time, especially when you're starting out, so that you can identify what effect that is going to have. When you're thinking about your pixel size, it equals your field of view divided by your matrix. Simple math, but it explains a lot of the confusion. If you increase your matrix and you maintain your field of view, pixel size decreases. So in-plane resolution improves, but your voxel volume will decrease and so will your signal to noise. So if you increase your phase matrix, your scan time will increase because you are collecting more phase encodes. If you decrease your field of view and you maintain your matrix, your pixel size will also decrease. You'll get improved resolution, but now you must ensure all your anatomy fits within your field of view, or you will get that aliasing artifact. Some ways to do that and to navigate that is careful planning and adopting to oversampling. Oversampling will increase your time though, but it will increase your signal to noise. Practical example for this could be if you're doing a knee, reduce your field of view around the joint and keep your matrix moderate so that you can produce excellent detail without exploding out your time. Another one is for abdominal imaging. You may keep your field of view large to avoid your aliasing, and instead you optimize with acceleration and breath hold time. A recommendation would be to always kind of calculate your pixel size when someone says more detail. Keep your optimization grounded and prevent over or undershooting. So when someone wants more detail, just ask for clarification on what they're really looking for. Next, your signal to noise is proportional to the average of your next, the square of your next. So the key is to understand averaging. So when we go doubling our next from 1 to 2, we do get a 41% increase in our signal to noise gain, but we will double our time. So what should we do? So when is averages and adding an extra next a good idea? Well, when you have a cooperative patient, when you have minimal motion, and when you need a moderate signal to noise boost without changing your resolution. So examples of this could be high resolution musculoskeletal imaging, could be your detailed spine imaging when your patient is quite cooperative. Same for your brain if your patient is able to maintain holding still for you. When is this a bad idea? When motion is the dominant problem. When you have breath holds, when you have a restless patient, painful positioning, in those kind of cases, increasing your time will introduce motion artifacts and will compromise your image quality and ability to produce diagnostic images. So the practical recommendation is if you need SNR, but your time is limited, consider whether you are unnecessarily spending your signal to noise elsewhere. If your parallel imaging factor is too high, if your bandwidth is too high, if your thin slices are too much beyond the clinical need, have a look at what you actually really need to answer the clinical question. Then the best move is to stop unnecessary signal loss rather than trying to buy back your SNR with time. So SNR is proportional to 1 over the square of your bandwidth. So it's a classic relationship. When you increase your receiver bandwidth, you increase noise sampled per unit. So your signal to noise falls when your bandwidth increases. By lowering your bandwidth, you can improve and increase your signal to noise ratio. This isn't a free transaction. Higher bandwidth will reduce your chemical shift displacement and reduces that susceptibility distortion. Usually we see that in our EPI sequences, but when we lower our bandwidth, which to get more signal to noise, we increase the chemical shift artifact, and you can increase your distortion depending on your sequence. So it really is a juggle with your bandwidth there. So you choose a bandwidth based on the clinical situation. If metal or susceptibility is a major issue, you can increase your bandwidth even though we're going to take a hit with our signal to noise ratio. And we can then compensate for that with our voxel size, coil positioning, or a moderate next/average. So a practical recommendation is teach juniors to treat bandwidth as an artifact control knob, and then secondary, a signal to noise ratio knob. If you lower your bandwidth to reduce your signal to noise, always check for that chemical shift of water fat interfaces and ensure it doesn't compromise the diagnostic task. We're nearly at the end, guys. Slide 30. So RTR generally allows for longitudinal recovery. So more magnetization is available to be flipped into the transverse plane. So when we increase signal, and often SNR, when we do this, but TR is also a direct multiplier of time in many sequences. So if you're working on a Siemens, you'll commonly see when it gives you a SAR option, TR going up is usually an option into there. But this comes with timing. It'll add time to your scan. TR is also a contrast knob. So when you shorten your TR, you increase your T1 weighting. A longer TR reduces that T1 and moves more photon density weighting into your imaging. So you can't just change your TR to chase signal to noise because you're going to affect your contrast. And this can then cause you to not actually have a weighting you want. So in the practical example, so in a T2 turbo spin echo, the TR is often set nice and long to minimize the T1 effects. When you're extending it further to give a little bit more diagnostic benefit and add more time, that can work really, really well. But if you're looking at a T1, the TR is chosen because you don't want to blow out your TR. Otherwise, we're not going to be able to have the T1 effects. We're going to minimize those T1 effects. We're not actually going to be producing the image we want to produce anymore. We're actually going to introduce a PD weighting almost, and we want to avoid that. So the recommendation is to treat your TR as a contrast choice. When you adjust it for time and SNR reasons, you just need to confirm that the TR is still within the scope of the weighting you want to keep it at, and that the resulting contrast will still answer your clinical question. If the goal is purely time reduction, more often adjust your phasing codes, your echo train length, or your acceleration before going to your TR. Next, a longer TE increases your TE or T2 star weight, but it reduces your signal because transverse magnification decays during TE. So in a GRE sequence, the T2 star decay can be quite rapid. So long TEs can lead to significant signal loss and increased susceptibility sensitivity. So here's a really good example of a brain MR that I have done. Believe it or not, that's my brain. So you can see that on the routine, we have a T2, but then what we've done is we've really dropped that TE right down. So we are losing our ability to have that contrast between the different tissues. And the last one is where we've gone crazy with our TE and we no longer are getting really any signal into there. So TE is usually set by contrast requirements. So like we just said in our imaging just there, when we reduce our TE too low, we are going to potentially lose our ability to see the contrast into there. So if your TE is also then very long, like our last image, we are going to lose our signal to noise or our image quality. So you need to compensate. This is an extreme example, these ones here. I pushed the system way harder than it needed to go on either end up with two undiagnostic images. The practical point is, if your TE is long, you should expect some lower signal to noise ratio. And if you need to compensate for that, you need to compensate with your voxel size, your coil selection, and potentially your averages and nexts. But be careful because increasing your time also then increases your motion. So my recommendation is just don't change your signal to noise ratio through a TE if it breaks the contrast that you're intending to achieve your weighting. Instead, protect the diagnostic contrast and then optimize signal to noise ratio with your other levers and your other options. If you are stuck with a really long TE and a low SNR, consider whether you can moderately increase your voxel volume or reduce your acceleration, but you will pay for it with time. Now, it's been great talking about all the stuff to do with MR, but we haven't really spoken about deep learning, which is something that's new and hot off the press and has been coming in and around the MR space for the last few years. So another thing that was beyond this, because I could ramble on for ages, was parallel imaging techniques, which we might be able to cover later on with everything MRI. There's lots of educational things coming out, but I just wanted to touch on the role of deep learning. These images down here are of the same eggplant, but one has deep resolve boost, so a Siemens equivalent of deep learning on it. So something that I love about the MR space is the new technology that's coming out, and deep learning not only just reduces the scan acquisition time, but increases our signal to noise ratio and our resolution, which are things that before physics weren't allowing us to play with that triangle. But all of a sudden, this example here, we've gone from a 4-minute sequence to a 1-minute sequence. And not only have we made it faster, we have gotten more signal, really robust resolution as well. So watch this space. We'll probably keep you up to date with some more parameter changes and practical applications of this. But I just really wanted to highlight the direction of which MR is moving and how we are rewriting a lot of these rules of MRI physics. And we're dispelling a lot of rules that used to be in place from the limitations of our systems that we're now going, you know what, we can push all these things, we can achieve really amazing images for only a fraction of the time. But keep watching this space. Everything MRI is bringing out free educational material to help you and your MR scans. So thank you, everyone. So my final sentence from this is MR optimization is about identifying what you can change without breaking the clinical question. That is always the premises of modifying things. So always start with what the question is. What pathology are we trying to see? And then from there, decide which corner of that triangle needs to be protected and which one we can move. So if the anatomy is small, critical, protect your resolution and earn back your signal to noise. If motion is the main risk, protect your time and accept that you will have a loss in your resolution or your SNR. If the image is noisy but motion is minimal, protect your time and buy back your SNR. Practical way to build confidence is to do deliberate practice. So after each scan, pick up a parameter and say, what would happen if I changed this parameter by such and such? Then compare your prediction to the reality and the outcome. This will build your intuition from a junior level up into a more advanced level. Everything in MRI is play. So just remember, the best protocol is the one that answers the clinical question in for the patient you have on that table at that time. It's not the one that looks the prettiest or a perfect phantom. It's, is my imaging going to answer my clinical question? It should always be at the forefront of your mind as an MRI radiographer. Thanks, guys, and thank you for listening to me for the last hour or so, and I hope this has helped.
I think that was great. So congratulations. And I don't know what to say, to be honest. I think that was a masterclass, to be honest. No, really well done. Sam, what do you think?
You took the words out of my mouth. I was going to say that was a master class, and it's so early over there, and you so focused, and it's amazing what you're doing for the community as well. So we appreciate having you here. We have a few questions. We also have our own questions. I don't know, Julian, do you want to start with the first one? I think it's from Pedro.
Yes, absolutely. What is that? Pedro, where are you? Oh yeah, I can see that. Well, what was actually one of the questions you touched base, I think, a little bit towards the end, and he was actually asking about AI, the impact about AI, like having like a finger scan in about 5 minutes with sequence around 1 minute. And this puts a little bit everything a question. Is it everything what we discussed tonight still important? And I'm gonna leave you answering, obviously. But let me just say that I think there is a certain level of knowledge even around the AI parameters, how to use, for instance, the deep resolve boost, which kind of averages do with that specific denoising. So I think there is a certain level of knowledge even on using AI. Of course, this will help us in many ways, but again, I guess even if you don't know how to use it, you will have implication on your image quality. It's not that AI automatically, poof, will be amazing images. Do you agree with me, sir?
I do. I agree that, like, even though we have AI available to us to help with it really does help with that triangle, you know? It makes the effect of the triangle harder to stuff up, I guess. It protects you in a lot of ways, but you're still held by a lot of the base rules. So you're still, if you're pushing your TE too low, for example, let's say for a T2 sequence, you've dropped your TR to 1800, unless you compensate, you're still going to get an intermediate signal for your result. Like if you don't put restore on to be able to lift your signal up, you're actually still probably not going to end up with the best contrast in your imaging. So AI will be there to help rescue, and it does really help accelerate, but you're still bound by a lot of the rules of physics. You can't, it's like the commandments, you can't break them. You need to follow them. This just gives you a really good structure on how to get there, but AI will enhance, it will not replace.
Yeah.
But it will make you think about, can I do this? And you actually can. A big thing is your flip angles for AI. We did a really good experiment where I work where we did brain MRs, and we did them with a flip angle of 70, 150, and then as high as the system could get it. And we asked our radiologists and our radiographers to pick which one was the low flip angle and the high flip angle. And with the deep resolve boost and the AI, you couldn't tell the difference. And that's a really weird thing to tell MRI radiographers, drop your flip angle. They go, oh my God, can I do that? And you actually, yes, you can, but it's only because the AI is assisting you so much for what you're trying to achieve. So it's forgiving. It's not going to save you if you butcher a protocol and you, like I said, play with 5 different knobs and you don't really know what you've done, and then it comes out. It's not going to give you a diagnostic image if you've played with too much and pushed the system too hard. So you still have to think logically about what you're wanting to achieve. But yeah, AI is
Zoe, I have
that
I
answered
have a
pretty much
follow.
Pedro's question.
I have a follow-up question on this because you're saying that basically the idea is you practice it and you go in the parameter and you change it, you see the results. We know how nowadays the departments are extremely busy. And if you have a junior staff member, how do you tell them to do this kind of thing? Do you believe the simulators, MRI simulators, could be a useful tool to practice the MRI triangle, or you think it should be with the actual patient?
I think ideally it would be with the patient, but agreed. Departments are wanting more throughput. You don't have time to sit there and play for 15 minutes unless you have a patient that's cancelled, or holy moly, you've got a lunch break, which is completely luxurious in the MRI field to have a full lunch break. That's when I would recommend having a play. But ultimately, the simulators are fantastic as well, though. If you do not have an opportunity to organically do it within the department that you're working in, simulators can be a really great way to get your head around where to click what buttons, what am I doing? Because if you're doing it just in your department, it's going to take you so long to build the confidence to be able to play and click things. If you're doing it on a simulator, you've already got that mind muscle memory. You already have a rough idea. It takes 80% of the work out. So I think simulators are fantastic when you're starting out. And if you don't have the opportunity in your department to have a play with parameters, that is fantastic option. Honestly, I think all junior MRs should probably spend a few days a month on a simulator just playing with things so that they can build that intuition themselves, because you are usually relying on the person teaching you to instill their knowledge on you. And if the person themselves doesn't really understand the physics or doesn't know the triangle very well, it's very hard for them to then communicate that to you in a way that's understandable and applicable. So I think simulators are fantastic. If you can get your hands on one, definitely use it as a tool.
Absolutely. I agree, because what you mentioned is a really good point, that you have to be lucky with the person that you land on your first job, because that person, if they don't know the physics, they're just a repetition radiographer or button pusher or something like that. You're not going to learn those things, and the triangle will just pass through you and you'll never hear about it. So I think at the university level as well, it would be interesting to have these simulators or in courses, and even at work, as you said, in this free time, you could just play around. Julian had played around with it. I played around with it. Maybe you as well. And I think it's really interesting to see what we can do with those simulators and just go completely ballistic with one parameter, and the image comes out in that way. And you're, oh, this is what happens. So I think it's really interesting that we use those because will make us understand physics in a very, very intuitive way. So from my perspective, I fully agree with you. I think it would be very interesting to have more people that come to the space to do and train with simulators for sure.
I think you touched on a really great point there, Sam, as well. Simulators give you this freedom to go, I'm not hurting anyone, no one's stuck in the machine, I'm not feeling guilty of leaving someone on the table for the next 10 minutes or asking my colleague to jump on the table for me to practice. And you can go wild with your parameters. You can blow your TR out to 15,000 and see what the effect is. You can, for a T1, drop
Sorry,
your...
there was the invasion of a cat.
Sorry, not even my cat. I'm sorry.
Yeah. That was a little bit the behind the scenes of an Everything MRI webinar, classic Everything MRI webinar. Moving to the next question, so I can see that Deborah is asking, when would you decide to add a filter to your result and images to make them look better? What are the downfalls? I think this is quite actually a topic that is usually sort of like underestimated, because when you have application specialists coming on site, they always mention about filtering, try this filter, and then we as radiographers sometimes we kind of like downplay the importance of filters, or we're not particularly interested from there.
I really love the fact that a lot of filters can be applied post-acquisition. Yeah. So I know for my Siemens scanner, I can go back into most of us will have a little suitcase at the top right. We can click in, we can reload up, and we can add in the different filters. So I believe it's have a go. Like at the end of the day, jump back into the sequence you've acquired and apply these different filters, because you can usually do them retro, after the fact, prospectively, and then have a look which one answers that clinical question better for what patient body habitus type as well. One filter might work really, really well with your standard average size patient, whereas another one might work really well for someone who is above or below an average as well. So I think if you can jump in after the fact and then reproduce these images with these different filters, produce them, have a look at them yourself, compare them all stacked up and see which one is actually giving you the most information. But yeah, from the scanners I've used, I've been able to go back like retrospectively and apply the filters. Is that the same for you, Gillian and Sam, as well? You found that you've been able
I have
yeah.
I have a tiny disclaimer here, because I have radiologists that notice when we use those filters straight away, and they call us and say, why did you use this filter on this picture? I want to see the raw picture. So we need to be very careful with the post-processing filtering of our images, because some radiologists will notice the difference and they will call you on it. So we can do those. I think some of them are very useful. We used to have them. But I would speak to the radiologists first, understand what their needs, and of course it's all depending on the patient you have in front of the table, the anatomy, the pathology. So you have to be very careful the way you manipulate the images post-processing, or if you do those filters, at least send the raw images as well, so the radiologist can have both worlds and decide what to do.
I must agree with Sam about this 100%, because I think one of the big question about AI implementation was about like filtering, that some radiologists were finding a little bit plastic-ish. Here comes liability. And I always wonder, what if a radiologist suddenly say, okay, I missed a lesion, but I wasn't used to this type of plastic images. So it's not obviously a justification, it's not an explanation, but liability is quite a tricky thing. So that's why filtering is something you want to be very careful about.
I think, Julian, liability is the biggest topic now with AI, with remotes. It's a huge thing. Everyone is talking about liability because we don't know where it falls. So we have to be very careful when we're dealing with these things. But yeah, I agree 100% with both of you on this one.
We got another question, Zoe, before we let you go, because I think you...
I have one more as well myself.
Okay, we get two. Yeah. I was wondering, I was about to say you might have plans for today because it's early morning. We might go to sleep very soon. But yeah, let's see. From Husman, who's asked, how can scan time be controlled using the TR in STIR sequences and fat saturated imagings with reference to SNR resolution, and how much TR can be increased or decreased in that sequence? So there is a question around TR in STIR and fat sat images, which I think is he means like spectral saturation and or STIR.
So yeah, so you can do this a couple of different ways, but ideally, because TR is more of a contrast lever as well, you have to make sure that you're not trying to drop your TR too low that your radiologist is going to go, hey guys, this STIR looks horrible. Why haven't you given me the contrast that I wanted? So if you're using, let's say you've got AI and a deep resolve learning into there, you can drop your TR lower, but you're going to have to compensate that by telling the scanner you want it to use restore. So a lot of the scanners now will use any leftover TR sample and filter it back into your image. If you went for a conventional approach, you can't usually drop them as low as you originally wanted to, because you will lose your ability to have that contrast that they want. So I think if you want a really nice STIR, they suggest going above 5,500 TR. And then with a T2 fat suppressed sequence, probably around a 3, 4, maybe 5,000 TR. And then if you're looking for your T1 fat suppressed, you really want to keep that TR low. I know some 3T systems say a rule of 700 to 1100 max. But even then, when you get to your 1100, you are pushing the boundaries of that. So you really want to be sitting kind of 850, 900 for your T1 fat suppressed pre and post contrast imaging into there. Now, you shouldn't be using restore for T1 sequences or PDs. Restore settings should really only be used for your T2 fat suppressed and for your STIRs, because you can introduce that TR regain and you can lose your information. So when you're trying to signal to noise and resolution with your TR, you still have to maintain that you're getting that really good contrast for that radiologist as well, because they will know if you drop your TR too low and you start losing your differentiation between your fat and your fluid. So it comes down to how heavily weighted does your radiologist want your stirs? Do they want a really heavy stir, or are they happy with one that is less contrasty between that fat and the water interface? So again, it comes down a lot to radiologist preference, and we are really at the whim of them because they're the ones with, like we said, the liability, and they're the ones that are reading those images at the end of the day. So I think a good idea would be, if you have an opportunity, is to experiment with your stirs. See if you can drop your TR, put restore on, and filter back in that signal from the TR to be able to keep that contrast nice and high. Another option could be for your fat suppress sequences is looking at your the fat suppression technique that you're using as well. If you're going for a joint on a Siemens example, you don't want to use strong fat suppression, you want to use weak, because that's actually going to give you a much better image, especially when you're coupling it with Deep Resolve Boost or an AI software. Typically, you want to be able to use the weak option, and it'll actually give you better fat suppression uniformity and good contrast into there. You don't want to be using your strong.
It's amazing.
Yeah, another.
I think we might need to do a part 2 of this webinar, to be honest.
think we might have
There are so
Talking-
many areas that deserve like a proper explanation.
Guys, talking about webinars before I ask my... Sorry, Zoe. Talking about webinars before we ask the last question and say our goodbyes, we just want to say that there's 2 webinars coming soon. The next one is just about the documentary that me and Julian did at Siemens 𝐿𝐻 headquarters. It's coming out in now in February the 26th, 6:30 p.m. So you're all invited to be there. We're going to broadcast live the first episode, and we're going to answer questions. And then we have one with Bill Faulkner about burns in March. So it's going to be on the 24th of March. So it's all about burns with Bill Faulkner. So we're going to post everything about it. But just because we're talking about webinars, we'll have pretty much every month webinars or podcasts going out.
Yeah.
A lot of free content for everyone. So we have one question for you as well, which is you were talking about noisy images that sometimes already answer the question, right? So you don't need to go the extra mile and try to fix everything. Sometimes you have the image, it's noisy, but you can answer the diagnostic question that you have. My question is, for junior radiographers, is this a compromise that you believe they have the knowledge to take? Because they are so junior, they want the best pictures ever, right? When I was working at the first time, and I had a liver scan, and my liver scans were noisy, or I couldn't get all the liver in the small FOV that I have, I always wanted to repeat it, right? Because I'm junior, I want to make the best pictures possible. But sometimes I wouldn't need to do that because my clinical question was answered on the images that I already got. So do you think the junior radiographers have that knowledge, or you think it's something they will learn with time?
I definitely think it's with time. I think it's a lot to expect a junior radiographer to be able to have the intuition to look at something and go, I think I've answered this question, because MR is multiple facets. Not only are we using the technology and thinking of the physics and trying to get the best image from the limitations or the constraints that we have, we then have to assess, is the protocol correct for the pathology we're looking at? And then we've got to look at our images and say, have we answered that question? I think that latter part is the last part of the puzzle that comes together for a junior MRI radiographer. The first 2 things come first. That last one is built from experience reviewing images. So I definitely recommend for all junior MRI radiographers, go in 10 minutes early or use your breaks or gaps to be able to review the day's previous MRs, read the reports, see what the image quality was like, and go, do I have to adjust my expectations? A lot of radiologists are very happy to talk about MRI image quality as well.
Yep.
So discuss that. If you're unsure, I think the biggest thing is staying curious and asking questions. Even, being in the field for like now 10 years as a radiographer, I still ask questions because there's so much happening and there's so much that you need to know. And we don't get the training to be the people doing the diagnosing. So we don't always know what's really needed in those situations. So I think, stay curious and ask questions. But yes, I think that last part is the last part of that special puzzle when it comes to juniors.
You
So
mentioned
never be
stay
afraid.
curious. You mentioned stay curious. I remember we had a podcast, Julian. I can't remember who said that to us. But
Yeah.
one of the last notes they gave us was stay curious. And you just mentioned it again because I think that's what me and Julian do all the time. We're always curious about these things, and that's why we keep pushing. And we hope that everyone stays curious. And because when we're kids, we're always asking why? And eventually we grow up and we stop asking why. And I believe life gets boring. So I think we need to keep asking why in MR and in everything in life to make it fun. So from me, thank you so much, Zoe, for this time. You've been amazing. It was a masterclass, and thank you so much for waking up so early to do this for the MRI community around the world. We really truly appreciate you, your knowledge and the kindness that you have to share with us on a daily basis. So from me, that's all. I appreciate everything you're doing, and I thank every single one of these people that are here today to learn with us, because me and Julian are learning every day with people like you, Zoe. And that's what we do. So I'll pass to Julian now. And again, thank you all
Yeah,
for
I got no much more to say. So, of course, that was never the idea that you were even minimally disappointed. I know you were the right person, the perfect person for this webinar. And again, I'm just throwing it here, but a part two might be needed. I can see there might be the reactions. Actually, thank you for breaking our Zoom, because we must clarify that we in order to keep this event free, we need to put a cap on our number of participants. And of course, I know that some people unfortunately didn't manage to come in today because of the number limitations. And that's why we also asked everyone to be on time. But this is how the topic was very hot. So we deserve a part two, especially for those people that didn't manage to attend. We'll post definitely the recordings, probably tomorrow, the day after. But I would say, let's put it just here. Part two coming for the MRI triangle, maybe end of the year. Well, we'll talk about. We'll talk about. We'll
Let's
talk
not
about.
make promises. Let's not make promises.
Exactly. Well, thank you so much, everyone, for attending. Thank you. It was much appreciated. Thank you, Zoe. Thank you, Sam. Thank you so much, everyone.
Thank you, everyone. Have a
Thank you,
nice day.
everyone, for jumping on.
Thank you.
Bye bye.